who is the founder chairman in India and the father of palliative care in India. The topic for today is on end of life care. We know that the duty of every healthcare professional is to mitigate suffering, and also it is every human's right to not only live with dignity but also die with dignity. With that note, I hand it over to you, sir, and I humbly welcome you for today's session.
So, friends, hello everybody. Can you all give me the customary mandatory smile to start with? Very good. Hey, see, Sri, notice the whole screen brightening up. Very good.
Yes, sir. We wish we also had the same magic like yours.
Oh, saved for future reference. Thank you. Hey, everybody, we are going to talk about something very important. Not only for your palliative care uh, practice, but for our everyday life. You all have loved ones at home. We are going to talk about something that must come into every single life. Not a happy thing to talk about, but it's important to think about it. It's important to talk about it. We are going to talk about end of life and end of life care. And I repeat, we are not going to talk about somebody else. We are going to talk about ourselves and our loved ones. I am, Sri, you are ready with the poll?
Yes, sir.
I am giving you a question here. Sri will administer the poll and please respond. Sri, please tell everybody what exactly to do.
Right now, you will be seeing a prompt on your screens. The same question which you are seeing in the PPT. Are you able to think about your online? So just make your choice, mark your choice, and submit it. We have already started getting responses, sir. 24, 25, yes.
What's the total number of participants, Sri?
Sir, 48 including us, which would mean 45.
You can very well include yourself, Sri, if you want to join the poll.
So since I am administering it, I don't have the options.
Okay.
Otherwise,
What
I
number
would have
did you say?
chosen.
40?
Right now, we have 54 participants. So
We have got only 39 polls.
39.
40. No, some people, this is not an easy question to answer. I'm sure some people must be thinking hard.
So shall I end the poll at 1 minute 30 seconds?
Okay, very sad about leaving behind the other 10 or 12 people, but yes, 60% of people are able to think about it. 23% no, that is 23% and 16% not sure. If it was not a palliative care group, I guess only about 1/3 of people would have said yes. That's what I usually find. So to the 22% of people who clearly said no, I wish you all immortality. To the people who are not sure, please think about it. To the people who are able to think about it, 60% of people, congratulations, because it is a strength. It's a huge strength to be able to think about it. Why? Why should you think about it? When you think that you are mortal, that life is limited, that thought itself, if you stop to think about it, will help you to lead your life meaningfully. You will be able to think about what really matters. All of a sudden, you may realize that the swimming pool that you wanted at the back of your house really is not all that important, whereas something else may be much more important. It's also that if you are able to think about it, uh, so I'm sorry, just give me a second. This is important, and it's very rude of me, but I'm going to take this call. As I said, you all have parents, grandparents, and someday you will have to be the caregiver. And at that time, it's not going to be easy unless you are mentally prepared. And also when our own time comes, if we know what we want, it can help us to die as well as possible. Unfortunately, the situation is not very encouraging in India. Dr. Sankhamitra, a British oncologist of Bengali origin who works in Australia, he writes, in India, the poor die in misery of neglect. The middle class die in misery of ignorance. The rich die in misery on ventilators. No one gets a pain-free and dignified death. Right now, one of her Pallium India's great supporters has her father who has been living with COPD for more than 25 years and who is in respiratory failure, has gone into the intensive care unit for the 5th time. This time, possibly the final admission. And that is sad. That is very sad. This happens only in India. So I don't know about some other countries, but certainly not in Euro-American countries. Friends, look at this. Sridevi will later share all the whole PowerPoint with you. And if you find the time, look at the papers. The first one, published in JAMA, is from Western European countries. When treatment was considered futile for patients in ICU, 90% of them were taken off life support systems. Life support was withdrawn and instead palliative care was given. Well, it's actually 89.6. Whereas the great intensivist in India, Dr. Rajagopal Mani, in his paper published 2021 finds that roughly 70% of people who die in ICUs die on artificial life support systems. What a horror. The other 30% are withdrawn in a cruel fashion and sent home with no palliative care, mostly. Is that life support given to 70% of people as they die important? Is that advisable? What would be important for the person in the last month? The 60% of people who are able to think about it, please tell me. What would be important for you? I'll tell you what's important for me. What will be important for me is my son's hand to hold, a final farewell to my wife, and a kiss on the cheek from my grandchild. They will be important. The ventilator is a hindrance. It will cause me agonizing pain and suffering, and the loneliness is inexcusable. So when you treat your patients, whether you are able to think about your own death or not, when you treat your patients at the end of life, let us keep this objective. What do we want to achieve? First and foremost, the person as comfortable as possible and in peace. As comfortable and as much in peace as possible physically. emotionally, socially, spiritually. Perfectly achieving all this may not be possible, but at least we can stop inflicting suffering at this point of time. And I'll remind you of the duty of care of a doctor as defined officially in India is to mitigate suffering. There exists no exception to this rule. At the end of life as well as in life, we have the duty to mitigate, so minimize suffering, prevent suffering, treat suffering. What will you do to achieve this goal at the end of life? When do you know that life is nearing end? As I said, Sri will share this PPT with you. And if you are not used to the palliative performance scale, here is it. So the person that I talked to you about, who is having COPD, is totally bedbound, receiving total care, but drowsy, is possibly at a PPS level, palliative performance scale of about 30%. And if somebody's palliative performance scale is 30%, in the hospice environment, without artificial life support, if it is cancer, they are likely to live. 80% possibility is that they will live for an average of 13 days, varying from 7 to 31 days. But if it is not cancer, as in the person I talked about, it can be very long. 24 is on an average, but can be as long as 176, coming out of ICU and going back into ICU. So please take a look at these two documents, the palliative performance scale and the prognostication index, and that may help you to give a general idea. But that's not so important as you're feeling like this person is dying. And when we come to the last few days, we focus more on the comfort than on physiology. There should be a balance between comfort and skin health. We may not change the position every 2 hours. If the person is finally sleeping after a long period of wakefulness, maybe you will allow the person to sleep for 4 hours without troubling him or her. And if the person is unable to drink, friends, this is important. When your own loved ones are nearing the end, this is very important. You would be in pain if they are unable to eat or drink. But remember, the tube that you may put in would cause more suffering. If dehydration causes symptoms, then you can consider hydration subcutaneously rather than IV. I hope in your course you have had occasion to learn about it. If not, ask Sri to arrange a session on this. I'm sure it must have been taught in nursing session. We would give rectal medicines rather than IV. And I will not put in a tube if at all possible. And I'll stop all unnecessary investigations. Parthasarathi Shaw was a well-known person who also writes. He was the former financial advisor to Prime Minister Manmohan Singh. And when his mother was dying in an ICU, he wrote, even on the day of passing, a specialist recommended a liver function procedure. When asked if it would end the coma, the answer was in the negative. Then why poke the needle in? If I'm lying there and wishing to be present with the family and to take a final look, why should you give me more pain? What's the point in doing one more blood study when you know that somebody is dying? So please ask, do we really need these investigations again now? Why do we give the multivitamin tablets? Why do we give the statins? Oh my God, the quantity of statins consumed by dying people is unimaginable. My good God, how does it matter? Cholesterol medication, not only cholesterol medication, multivitamins, minerals, free radical scavengers, and invasive procedures would be the worst offenders. You may continue antibiotics if they are needed for well-being. The objective is not necessarily to treat the infection, but it is to cause the fever and suffering of an infection. Avoid hospitalizations, but certainly avoid intensive care. Sometimes family may not feel confident to handle this at home. So however we say romantically the death should be at home, it may not be able, the family may not be able to handle it. And are you able to reach them when they need us? Ash, if a call comes at 2 o'clock to Pallium India, are we able to visit the patient at home? So long as we are not, maybe there are limitations. So what we do is call an ambulance, this is a number, bring him along, we look after them. If necessary, hospitalize, but an intensive care unit shouldn't happen. Even towards the last stage, we may still do a surgery to treat a total intestinal obstruction that is causing immense pain and breathlessness by distension of the stomach. We may have to do a colostomy. Sometimes, rare. As far as possible, we will not send the patient back for radiation or chemotherapy if it is cancer, unless it's for a pain that's difficult to control arising from bone mets, or the person has bad vertebral metastasis. You may want to prevent paraplegia even in the last month of life. So, unless it is meant for quality of life, aggressive interventions are avoided. And unless there are times when you may still put in a feeding tube. Suppose somebody has a cancer here, throat, unable to swallow. The person says, I'm feeling hungry. You don't have a good medication for that symptom except food. That may be a case. The person may say, a tube, anything. Okay, peg is fine. Or do a gastrostomy, but let me get rid of this hunger. Then you may do it. Or if there's a tube in place already, the person may choose to keep it there. Then at least medications can be easier. But those are about the physical aspects of care. Of course, you all know. I don't have to now talk about symptom control. Over the last so many sessions, you have studied symptom control well. So I will not pursue that in detail. But let us now go to the psychosocial and spiritual issues. Particularly the spiritual issues are what I am addressing in this particular slide. If you care to sit down beside me, you may and I want to talk. This is not possible on the last day, I'm sure. I hope your end of life care will start with preventive action, planning. None of you, my colleagues, including Hashmat and Sripriya, know what is it that connects me to this world most. I may have my own answer. People have different answers. And listen to my story. Just sit beside me and ask me, how are you, etc. And then, would you like to talk about your life? Where were you born? Ask me those questions. I might never have told this. Hashmat, Sripriya, maybe you do not know enough about your own parents, the stories of their childhood. Papa, tell me some pleasant thought from your childhood. And they may then tell you how they got the first place in maths every year in the school. And that would be important for them to share. And as they tell the stories, validate. Okay, I wish I had the chance for more education. Don't think about it, Papa. Let's say, Papa, I also wish you had the chance for better education. That must have been very painful for you not being able to go to college. And if they say, I wish I had done this, I wish I had not done that, I wish I had stopped smoking. Don't at that time point out mistakes and don't say, no need to feel guilty. I see that that must be a painful thought for you, Papa, but I love you. That should be the response. And in the story, when the acknowledgements come, Papa, but despite all those problems, you still got first place in maths. That's remarkable. Dad, I am proud of you. Acknowledge achievements and respect silences. Halfway through, your Papa may stop talking. Be there. Don't say, why, Papa, tell me the rest of the story. No, wait. Those silences are important. They are looking into themselves, into their very souls, and reconciling with very thoughts. If you sit there long enough, they will come out with some profound thoughts. And that would be your privilege to listen to. So it doesn't have to be your Papa. It can be your patient who have never had a chance to tell these stories. But you cannot do it every day to every patient. I know you are busy just as I am busy. But sometimes when you can, remember, these can be the most precious experience for that person's life. And sometimes, even for you, you learn so much about life. The person who seems just another case of CA lung in bed number 3 suddenly emerges as a wonderful person who teaches you with the story of his life or her life. And I repeat, respect silences. Be there. Who is going to read this out for me? This story of from Winnie the Pooh? Sheila, you are the person that I see right in front of me first. Would you like to unmute and read the story for everybody?
Sure, sir. Good evening,
Winnie
sir.
the Pooh and the Piglet.
Today was a difficult day, said Pooh. There was a pause. Do you want to talk about it? Asked Piglet.
Sorry, Sheila, that pause is important.
Okay, sir.
When somebody... No. I'm just adding on to what you read. When somebody says something and stops at a sentence, don't immediately poke more. Pause. Wait a second to see if more is coming. If not, the Piglet's next response is great. Yes, Sheila, please continue.
Do you want to talk about it? Asked Piglet. No, said Pooh after a bit. No, I don't think I do. That's okay, said Piglet, and he came and sat beside his friend. What are you doing? Asked Pooh. Nothing really, said Piglet. Only I know what difficult days are like. I quite often don't feel like talking about it on my difficult days either. But goodness, continued Piglet, difficult days are so much easier when you know you've got someone there for you. And I'll always be here for you, Pooh.
Thank you, Sheila.
Welcome, sir.
Did you get the story, everybody? Sometimes they don't want to tell the story. If you can find the time, it's good to be there, just be there. And especially nearing the end of life, that having somebody there is so important. Here is another question for history. Second poll, please.
Yes, sir.
Talking about connections. What connects you most to this world? Your home, your family, God, faith, religion, your occupation? Oh, straight away, some people have said their family. Divya says nature. Arun, that's an unusual answer. That's I don't say it's nothing connects him to this world. That's possibly the ultimate, either in frustration or in the ultimate spiritual well-being. This is what Jainism talks about. This is what Buddhism talks about. Many religions talk about it. Detachments. No, nothing binding you to this world. But for the majority of people, it's the family. Hey, friends, now you see why it's so important to get people out of ICU at the end of life. That's so important. For some people, that tree outside the window, the persons, 3 people who said home, it is not just being, of course, in your own bed, your own side of the bed, but also maybe the view that the tree that you see outside the window. And see, what this shows is that we are all different. Don't make assumptions. Don't make an assumption that it's always your home that you want to. May not be for some people. They may feel more comfortable in a hospital room. As you remember, my teacher, doctor, gynecologist, the oncologist's mother, who refused to go home, she said, I will live here and I will die here. And she died there. So it depends where they are feeling safe and comfortable. And if for the 5 people who are connected most to this world by religion, please respect that. But those 5 people, to those 5 people, you find it important. Everybody may not find it so important. It may be important, but may not be the most important. And don't go and push God down their throats. Thank you. Was there anything else worth mentioning in the chat, Sri?
No,
Okay.
sir. Others had
Okay.
responded family only.
Yes. Thank you. So I'm moving on. So I am unable to get that chat message out of my. Sorry. Okay. So rebuilding connections involves, if there are unfinished business, that there must be an opportunity. The person, nothing is important to the person among my list. I just want to make my will. I don't want my children to fight between them. And somehow, perhaps that is more important, dear friends, than giving that morphine. We have had to do this, and that is important, very important. So, unfinished business may be just one more phone call to a friend, one more wish to be conveyed to a brother with whom I have quarreled 3 years back. And especially for those people who find religious practices very important, at any cost, permit that final wish, if at all possible, like a last trip to that particular temple, like the last communion, Holy Communion. Those things have to be made available. And if a hospital says, no, we cannot allow a priest to go in and do all those things in the ICU, I would say, sir or madam, you have no business to be in healthcare because you don't know what is important. Restoring broken relationships, as I said, like the long lost brother, establishing connection again, permitting an opportunity to cry together again. And sometimes people who are divorced or separated, they have grief, disenfranchised grief. Nobody else will understand. But they have lived together for 17 years. And when somebody is leaving, they may want a final farewell. Ensuring the family's presence as much as possible. And if the family is not there, you become the family. I become the family. Hashmat becomes the family. Supriya becomes the family. And this is happening more and more in our generation. Don't leave them. Allow them to go out of this world disconnected. Somehow establish a reconnection or build a connection. And particularly mindful when children are the main caregivers. Oh my God, this is the most painful thing. Nobody thinks about how much that girl, 10-year-old girl, would be suffering. She is the main caregiver. Everybody gives her instructions. Who cares to understand what she is feeling? And of course, it's not only about children. All caregivers need care and support with what they are going through. They are not just bystanders. They are our objective of work. They are caregivers who need support. So, who is going to read this? Jyoti, I see you next on the screen. Would you like, this is an article that came, I have given the link there. When you have time, please read this article. It's written by Sindhu in the Hindu and about her dad's death. Will you read it out for me, Jyoti?
Yes, sir. My 84-year-old father, my best friend, was enduring raw, intrusive medical procedures against his own wish. All skin and bones, he looked defenseless and at the mercy of doctors, his arms tied up, vulnerable and agonized.
Something common between Sindhu and Parthasarathi show was that on the last day of their parent in the ICU, they heard about palliative care. Sindhu actually went to her dad and said, "Dad, tomorrow morning I'll save you from this place." Because he went on saying, "Help me, save me, save me." But 4 o'clock she got the call saying that he was no more. Parthasarath's mom was the same. The final day, that link is also given for the article. He heard about palliative care, but it was too late. Now, this we know is not good. You and I know that this, I hope everybody here agrees that you do not have a duty to prolong life of poor quality against somebody's wish. But the habit continues, the practice continues. We'll come to the why of it. This is from Choosing Wisely India. The publication is there. 2 of the 10 guidelines there in this document. refer to palliative care. One, start palliative care early in treatment of cancer. And secondly, do not treat patients with advanced metastatic cancer in intensive care unit unless there is an acutely reversible event. But you know what happens in cancer institutions across the country. 320 cancer hospitals are members of NCG. But so far they are not able to practice it mostly. Some are, but mostly not. Part of the problem is that very often people have a mistaken feeling that withdrawal of life support is euthanasia. In fact, a Supreme Court order itself calls withdrawal of life support euthanasia. But this document, you will find it on the net, free download, from Bioethics Unit of ICMR, lays out the meaning of several terms and definitions. So what it says is, euthanasia is killing. Allowing natural death is not killing. When we withdraw artificial life support, we are only allowing natural death. There cannot be a term called passive euthanasia. Even though the Supreme Court order has used that term, possibly from Wikipedia, not from scientific literature, passive euthanasia is a misnomer. Withdrawal of life support cannot be euthanasia. And euthanasia has to be, is there an act? Even if you are connecting the drip and leaving for the patient to open the tap, after all, you are connecting the drip with potassium chloride or whatever. So any euthanasia is active. The important thing is, by withdrawing a ventilator, please understand, we are not killing anybody. We are allowing natural death. When you have enough time to spend your patients and they are able to talk about it, the 60% of people who are able to think about your own death will find it easier to talk to patients about it, or families. You don't straight away go and ask the same question, are you able to think about your own death? It starts by, do you know what's happening to you? What's your understanding about the illness? What's your understanding about the cure? And when you ask those kind of questions, most of the time they themselves may say, bring up the word death. Or they may use euphemisms. And when they are able to talk about it, you are able to ask, but what do you think? Or we can use this strategy. When my time comes to be ill, I want to be at home. What about you? And you may be able to get them to talk about their wishes, and we may then be able to sign an advance directive. I know the majority of people in this group are young. Nevertheless, if you care to, please write your advance directive. And then you may take it to your grandparents and the parents and say, Mom, Dad, I have written this document. And they may say, what do you think about it? And they may say, I also want to do this. Or they may say, why are you talking about inauspicious things? And you may have to continue the conversation there. So according to the Supreme Court judgment in 2023, ladies and gentlemen, good news. The document that I have written and got countersigned by a gazetted officer is valid and binding on you as my physician. If I have in it, I have said that if I have an illness from which recovery with reasonable quality of life is not possible, I deny all interventional treatments and life prolonging interventions. And now you have a responsibility to respect that. Of course, the Supreme Court judgment also brought in some complicated procedures. We don't have a law for this in this country, by the way. In 2006, the government had initiated a law creation, but then they did not pursue it. And so the judgment that time, in the absence of law, what goes as law, equivalent of law, is a Supreme Court judgment. And this five-member bench of judges in 2023 gave this verdict, which is valid. Advance directives are valid. Withholding and withdrawing life support is needed and can be done. But if you are already on an artificial life support system, the Supreme Court has made some conditions. A three-member board of doctors in the same hospital, the Supreme can ask you and two colleagues to be the board, and you will have to certify that this is okay. It can be done on the same day. But then you have to inform the DMO, and an external board, preferably within 2 days, of three doctors will also have to certify this. This means, ladies and gentlemen, think thrice before you put a dying person on the ventilator. Don't escalate aggressive treatment. Withholding is so much easier than withdrawing. But this is the law. And lawyers advise us that all this becomes valid only when there is a conflict. If the patient, if conscious, agrees to withdrawal, or wants withdrawal, or if he is not competent to take a decision, the immediate family are agreed, and you agree that reasonable chance is not there for return to reasonable quality of life, we might as well switch to palliative care. Then we should withdraw life support. But if there is a conflict, then you have to go through this process. Conflict means of the three children, two say okay, but one is not available. He is coming tomorrow. He comes and says, no, do everything for my dad. Don't let him die. Then you will have to work with that person also. In those cases, we may have to go through the process. In the link that is given on the bottom of this slide, I have given the link to an advanced directive format. I would request you to look at it. And whoever wants to, download it, print it, type it, inform your family, and get it signed by a gazetted officer with witnesses. The most important part of an advance directive is not signing the document. It is getting the family on board. Unless they agree, the doctor will not care about the document. They know that you will not go to court after you are dead. The living family will contest. So the most important thing is to carry the family along with you. And I would recommend that whoever is brave enough, please help your own parents or grandparents to arrive at this spot so that unnecessary suffering can be avoided. This is not from any official document, so I'm not giving any link there. This is my perception. I see Dr. Achyutarama Srinivasa Varma in theater gear, keenly looking at the documents. Doctor, this is only my perception. I believe the biggest problem is with us doctors. We believe that we have a duty to sustain life, which to us means prolonging life, even if even in terminal illness, even if of poor quality. This is the biggest problem. And of you, I usually find people who have recently qualified have more of this problem. It is only for the last 25 years that every dying person started getting put on a ventilator. It didn't happen till then. Till the mid-1990s, this disease was not there. We have a mistaken perception of duty of care, that we have a duty to prolong life at all costs. And of course, the family's attitude also matters. Save my dad at any cost. Friends, it is also the way you convey the news to them. I heard a lecture by a friend, a doctor. He says, if you go to the ICU and get the family and ask them, his condition is very critical. You want everything done? Will any family say only half of need be done? Of course, they want everything done. But everything rational should be done. That's not the right question. The right way of conveying it will be to convey the real state of affairs to the person about the very almost none chance of recovery. And if they say, no, a miracle may happen, maybe you will have to go along with that. But if the family is adequately helped, they may eventually say, it's okay, doctor, let me go in peace. Of course, societal factors, including religious factors, will come in. And because the court order called it withdrawal, passive euthanasia, some religious orders have immediately come out with against it. And legal position is not clear very much because there is no law. But as I said, most of the legal tangles have been solved. It is the others that are problem. And I honestly believe that we, medical community, are the biggest problem here. We have a duty not only to do the best for our patients, but also to talk about it in the community. A 2022 Lancet Commission report asks us, bring death back to life. Death has become a stranger. In my youth, death was not a stranger. It was happening all around us. But in nuclear families, children grow up without seeing death, and it is feared. So maybe some of these things, especially about the horrors of an intensive care death, need to be brought out to the public. And we need to educate our colleagues and ourselves and the public about how end-of-life care can be made as comfortable and humane as possible. I see that we have some time for discussions, and I'll hand it over to Hashmat for leading the discussion.
Session. Sir, I couldn't see any questions in the chat box. Participants, if you have any questions, please unmute, or otherwise, please post it in the chat box. We can take it for discussion.
Good evening, sir. I'm Dr. Prasanna Menon speaking from Thane, Maharashtra. Just needed your advice on one aspect, and I also wanted to share just one of my observation. Like as you said, the nuclear family, the people are very scared to even hear about death, or even if they come to know that there has death happened in their nearby vicinity, they're very scared to handle, and how to handle it becomes a big question. So in our palliative care, we always make sure that the family members are very comfortable in handling after death scenario, like, the body preparation in the most holistic manner, handing over the body to the family, explaining to them about what type of cremations are available and what they should opt for if they're comfortable, that is electric and the other method. And similarly, they should take the papers from the crematorium or from the church, which are some valid documents which needs to be given or rather taken to the corporation. If at all they have to get a proper certificate from the corporation, death certificate. So all these kind of advices we give, because most of the people these days don't know how to handle the affairs after the death. And this is one observation which I made and I thought I should share. And sir, I needed one.
Dr. Prasanna, let me
Yes, sir.
respond to that.
Yeah.
First, thank you, Dr. Prasanna. This is one aspect that I did not even mention. Ash and Sri, Next time I am talking about end-of-life care, I should include it. Thank you, Dr. Prasanna. Very important. The respect given to the dying person.
Yes, sir.
Respect given to the dead body.
Yes, sir.
Assistance in what is going to happen later.
After.
Our executive director usually is the one to ring up the cremation place and make arrangements for him. So these are always remembered with gratitude,
Yes.
or if
Hello,
they
sir.
don't receive, if the
Hello.
Dr. Achita, will you please mute your microphone? So if we treat them without respect, if treat the body without respect,
Yes, sir.
it is very, very much resented.
Yes.
So thank you, Dr. Prasanna. Your second point.
Sir, just one opinion I wanted of yours. I respect whatever you say. Definitely, whenever there is a terminal case of cancer or a stroke patient who is on ventilator, not doing so well, each one of us, including the treating person as well as the family, know that we are not going to give a quality life. They pull the patient out of the ventilator. They take a discharge against the medical advice. Obviously, you can't do anything with this person at home. So they come to the palliative care. Now, the patient already comes with a Riles tube. Patient comes with a tracheostomy, a catheter to the palliative care. So over there, what we think we should give a comfort treatment, whatever possible within our limit. Say, for example, a few feet through the Riles tube to keep comfortable, grooming, avoid the bed sores, change of position. If there is already tracheostomy tube in situ, just connect the oxygen concentrator, keep them fresh. Because I have also seen that these patients hardly remain for 7 days, 10 days, 15 days, max to max 20 days, and they pass off. They go very peacefully. This is how we are handling in our palliative care. But there are at times relatives who will come and say, don't even give that much. Don't give water, don't give feeds, don't give oxygen. That is very cruel. And I end up saying, why don't you take home and do nothing? Why are you making us party to this kind of a cruel deed? So we have to make them understand that we are not doing any aggressive management. We are only, whatever tubes are existing, we are only supporting that. And we know in our experience, max to max 2 days or 10 days or 15 days. That's all. And slowly, gradually, very peacefully, without any trouble, they go away. That is the passing away with dignity. Sometimes even when they are coma, they are responding to some of our talks, like, breathing. I mean, after the talk is over, I will just share one of the videos in the group for somebody to understand. Patient is in coma, but as I talk, he's breathing very forcefully to respond to what questions I'm asking. So relatives force us, saying that don't give water, don't give feeds. It is very cruel. And of course, we have to put our foot down and say, no, if that is the case, then please take the body home. Take the person home and do whatever you want. Because people are sometimes very cruel, sir. Very cruel, sir.
Thank you, Dr. Prasanna, for giving your points. I'm glad you brought it out because it gives me an opportunity to say some things which may be against your beliefs. You call it cruel. Your act of continuing the life support measures, feeding, for example, in an unconscious patient, if the person is hungry, absolutely no issue. And even I do not always usually recommend removal of the nasogastric tube in a hurry. But there comes a time when the life may be prolonged. Remember, for somebody who is unable to express a view and who may be semi-conscious, every day will be intense suffering. And by feeding that person, you may actually be prolonging the suffering. You must think about it. You may be prolonging the treatment, and then from the patient's family's point of view, you are the cruel person who are stretching out the dying process. I believe they are the ones who love the patients, and we should not be judgmental. One of the fundamental principles of medical ethics is not to be judgmental. Now, one person that I have gone through a lot of people's stories. And this story is from Mumbai, actually in a patient with after a stroke, a 93-year-old woman. The family decided to stop the feeding. The person was totally unconscious, and the medical system was rather cruel. And they used the word cruel, like you did. But then the family then because all three children were unanimous. My mom, this was a doctor, the patient was a doctor who actually did voluntary work in the slums. My mom always said, don't subject me to this. What you think cruelty may be the kindest thing from their point of view. I don't think we should be judgmental. I don't think we should be angry with them. As unless you think they are suggesting something that is going to cause suffering for the person, I think we have the responsibility to go along with them ethically. So that's my point of view. I'm sure this one discussion over 2 minutes is not enough. Dr. Prasanna, at another occasion, Sri, please make this happen if Dr. Prasanna would like to. I should have a conversation with, I would like to have a deeper
Yes,
conversation with Dr.
yes,
Prasanna
sir.
on another occasion. In the
Yes, sir.
meantime, are there any other
Thank you.
questions?
No,
Sir,
sir.
I have a question, but it is not related to end of life care. Is it okay if I ask?
You please, doctor, please ask the question and we'll decide whether to answer it now or later.
Okay, sir. Myself, Dr. Pooja, sir. I'm working as a physician in Karnataka. So I came across two patients, like in OPD, that one patient with heart failure, sir, with low ejection fraction, like there is nothing much they can do. They have told from a cardiology side, sir. So he is on a diuretics, and for his BPH he is on tamsulosin. Today he came to me with giddiness. There was a slight decrease in like postural drop was there. So I wanted to like I was not sure, sir, what to do because he was on beta blocker and even tamsulosin causes postural drop and even diuretic causes postural drop. So like I know that case is for a palliative care, but if I stop diuretics, he will develop breathlessness. If I stop beta blocker, his like he will have tachycardia and again symptoms can worsen. Tamsulosin, it is like again giving him lot of pain if we are not treating the obstruction. So what I
So,
should have done, sir?
Dr. Pooja, I'll give you a brief answer, and if you want to discuss it in detail, I will stay back
Okay.
after the meeting if Sri Priya will allow, or we'll get connected personally. But this could be of interest to everybody, and it is related to end-of-life care. It's related to management of symptoms. End-of-life care is not only about the dying process. It's about what is to
Yes,
proceed in the previous days, weeks, or months. So here you have mentioned three medicines, all of which are
yes,
necessary for his well-being. So without that,
yes, sir.
his suffering may be more. So sometimes we have to accept the lesser suffering. The giddiness is troublesome. Will the person
Yes, sir.
manage okay with half the dose of tamsulosin if they are taking 0.4 milligram? Will he be okay with 0.2 milligram without so much of giddiness? Maybe try it. Can the person be drink more, which may reduce this? If he is dehydrated, can that be treated so that the symptom becomes less? But if, okay, those are practical things that we may consider. Or does the person say, okay, even if it's okay, but I suffer this giddiness? We may have to think about it, not immediately act. So sometimes the important point is, if there are two conflicting symptoms causing suffering, we may have to choose to
Yes,
live
sir.
with the lesser suffering. What,
Okay,
what
sir.
is lesser suffering is not to be decided by Dr. Pooja. It is to be decided by that person.
Patient. Yes, sir. Patient.
Thank you, Dr.
Okay,
Pooja.
sir.
No, it
Thank
is
you,
not
sir.
unrelated. This was an important question. Thank you for asking that.
Thank you, sir.
Dr. Vedavati, your voice is breaking. Now, will you try? Vedavati, sorry. Will you try again? #3, what's happening? Do you have an idea what's the problem?
No, sir. I think that was unmuted by mistake, I guess.
Okay. Sri and Hash, I leave it to you to decide when to stop and proceed with the case presentation. I see that it is 6 o'clock now.
Yeah, sir, I think we can stop now because there are no questions in the chat. We can move to the case presentation. I think
And
that
if anybody has any pending questions that you would like to discuss with me, Sri Priya will type my email ID in the chat box. Most welcome to email me or to inform Sri Priya.
Thank you, sir. Thank you for joining us today.
Dr. Bharat. So you may start, Dr. Bharat.
Yes. Good evening, everyone. This is Dr. S. Bharatraman. I'm working as a duty medical officer in Atulya Assisted Living. I like to brief about Atulya first because we deal here with many clients. First, we deal with assisted living clients, and second, we deal with dementia clients, and third, we deal with palliative care clients, and we also deal with transition care clients. And this client, 67 years male, came with the diagnosis of carcinoma right lung with lymph nodal hepatic and brain metastasis, metabolic encephalopathy, sepsis, systemic hypertension, Helicobacter pylori gastritis, stage 3 pressure sore on sacral region. So the presenting complaint when he came to Atulya Assisted Living was actually he was first treated in a private hospital outside for his cancer. And while coming here, they came with the idea of treating him with the palliative care. So he had low Glasgow coma scale, both leg swelling, pressure sore over the sacral region, and he was not able to mobilize due to weakness of the left upper and lower limb. The history of presenting illness, 67-year-old male with carcinoma lung and brain metastasis post radiotherapy was admitted with the complaints of weakness of left upper and lower limb for 3 weeks. He was diagnosed to have right parietal occipital region bleeding and was intubated, and tracheostomy was done in the outside hospital. He developed sepsis and he was treated with antibiotics accordingly. And while coming to Atulya, he was on Ryle's tube feed, Foley's catheterization, and tracheostomy site care. When he arrived here, while I was examining, I saw that he was fair, he was dehydrated, afebrile, he had pallor, bilateral pedal edema, he was on tracheostomy tube, Ryle's tube, and Foley's catheter in situ. His vitals were BP was 140/80, saturation was 98, temperature was 97, pulse rate was 98, capillary blood glucose was 104, temperature was 98. In the systemic examination, S1S2 was here. In RS, RNT was present bilaterally and basal cresps were present bilaterally. Abdomen was soft and bowel sounds were present. In the CNS examination, he was not obeying to a command, but his GCS he spontaneously responded to eye opening was 4, and VT and motor response was 3. In the treatment, this treatment was given in the outside hospital, not in Atulya Assisted Living. He was treated with radiations to brain, with intensive modulator radiotherapy with 3000 mic plus CGY in 10 fractions. 2 units of A negative PRBC transfusion was done with pre-medications. In echo, it was with mild concentric left ventricular hypertrophy, no original valve motion abnormality, grade 1 left ventricular diastolic dysfunction, mild tricuspid regurgitation with ejection fraction of 61. They have taken a core biopsy from his right lung mass with the histopathology examination report revealed infiltrating moderately differentiated adenocarcinoma. In the pulmocore 12 gene panel, it revealed EGFR exon 19 deletion. In PDL SP260 Ventana, it revealed tumor proportion score of 0%, combined positive score. Physiological aspects. He was a 67-year-old married man with his wife and son. They were Tamil people, and they hailed from New Delhi as his son was working there. And they had no hope, and they had no idea what was palliative care, and family needed to know the end of life care management, and they had some financial issues also, and they needed emotional support and palliative care. Medications given in the hospital, they have given antibiotics like meropenem 1 gram 3 times a day, polymyxin B 7.5 lakh IVBD 2 times a day, teicoplanin 400 mg once a day, caspofungin 50 mg once a day, injection Hepamers 150 mg per 100 mg. It was an amino acid with L-ornithine and L-aspartate, digestive enzyme pancreatin, glutathione 600 mg IV once a day, enoxaparin 60 mg once a day, cefixime 200 mg in a rice tube feed. It was 2 times a day, ursodeoxycholic acid 300 mg twice a day, levetiracetam 500 mg twice a day, trimetazirin 35 mg twice a day, modafinil 100 mg twice a day, because they were doubting about narcolepsy. Tablet atorvastatin 20 mg at the night, and they also gave 20% human albumin once a day to compensate the blood volume loss. And they gave levosalbutamol and ipotropium per nasal 3 times a day, and nebulization budesonide per nasal thrice a day. So the main concerns were he had bilateral leg swelling, there were pressure sore issues, and he was on Riles tube feeding, and he was also on tracheostomy care and with Foley's catheter care. He was not able to communicate with the family or with me or with the caretakers or the nurse. Summary: 67-year-old male with carcinoma right lung with lymph nodal hepatic brain metastasis who underwent radiotherapy to brain with intensity modulated radiation therapy, 3000 CGY, in 10 fractions with pressure so present over the sacral region, stage 3. He needed of prevention of bed sore, tracheostomy care, and Foley's catheter care. Family needed palliative and emotional support, palliative care and emotional support. So my discussion points are: what is the treatment options available for pressure sores? How to inform the prognosis to family? How to manage nutrition and Riles tube feeding? Is radiotherapy required for this client? Is physiotherapy required for this client? And is resuscitative measures needed even when a client is in palliative care management? Thank you.
Thank you, Dr. Bharat, for bringing such a
Thank you.
nice piece for today's presentation. So based on this discussion points, as well as based on the case, I want the participants to come up with your questions so that we can start the discussion. I don't see any questions in the chat box. And Dr. Bharat, I would like to ask you, based on the session that we had right now, what do you think can be the best for this patient? Because now you have heard a session from Sir. So based on that, and after you have seen this patient, I think you know a lot more about this particular patient and the family. So what would you think? And also, what was his performance scale, palliative performance scale? And based on that, how do you think we can move upon, and how can we like plan his end of life? So what are your points on the same? I just want your input first.
Sure, ma'am. So in Atulya, we have 9 facilities, ma'am. I have gone to 4 facilities in that. I have seen many palliative care clients. In that, why I chose this person was because the attenders were so friendly to us. They understood us very much, and they were very clear in how to manage him. And in the same way, we also had an idea of how to treat him, like making him very comfortable in a social way, make him socially active in a spiritual way and in psychological support. Socially, what we made was we made the social workers to go to his room and make him involved in some activity. They tried their best. And in nutrition, what we did was we had a nutrition here, and myself, we too were involved in the nutrition progress. What we did was we made the best dietetic chart for him, where the rice tube feed is given in a liquid form in the morning, afternoon, and night, everything. We made it into six times a day. We gave him a protein diet, diabetic cure, like that we gave. And we also gave him a proper physiotherapy so that he was able to, he was very stiff and he was not able to mobilize also. So we gave physiotherapy thrice a week. So we made the nutrition involved in this. We made the physiotherapist involved in this. And from my side, what I did was, if he had any symptom, for example, he had a fever and he had any symptom like vomiting or nausea, anything, so we'll treat him in a way that only the symptoms are treated and not disturb him. So very comfortably we handled him, and at the last he demised, but in a very peaceful way. He was not disturbed or something. In a peaceful way, he had a demise, and his family was also very acceptable for that. They understood us and they told, okay, we know that. So it was a very peaceful and very comfortable death for him. And from the family also, we had a very good communication. So all the boxes were ticked in him. So I chose this client.
Thank you for such a nice explanation, Dr. Bharat.
Thank you.
And yeah, so I could see Sir is here. Sir, if you want to add something on this.
No, Ash, I think between you and the participants, please proceed with the discussion. And if I have anything specific to say, I will add that.
Sure, sir. So yes, this particular patient, I can see there were many things that were to be done, and obviously Dr. Bharat has given his from his side, he has done everything well. So we can just see how we can, like, correct it. First thing is, the first question that he has put up is the treatment options available for pressure sore. So obviously in a patient who has a pressure sore, it is very important that we maintain the hygiene as well as the skin. So the skin, we need to look into the skin every day, and as you know, as sir said previously, for a person who is going into end of life care who has distressing symptoms, it's not that you have to position the patient frequently, but apart from that, you give a proper air bed at your setting, and also you give a position change every second hourly. And with respect to the pressure sore management, you look into the pressure sore every day. That is very, very, very important as a doctor, as a team. I would say as a team, as a palliative care team, whenever you go and see the patient for rounds, make sure that you open the wound and just see how the pressure sore is. Look for any any discharge. If there is any tunneling or anything, you just look into it. How is the granulation tissue and all of it, you just have to see, and then plan the management accordingly. And also, in a inpatient setting, we can actually do twice a day dressing whenever it is necessary. If there is more of a discharge or something, then you can do a twice daily dressing. Or sometimes, if you think that only once a day if it is needed, then you can make it according. It all depends upon your level of understanding, and you can do accordingly. So that is something which is very, very much needed, because he has a pressure sore in the sacral area. So position change as well as a proper pressure sore management is very, very, very important with respect to this patient as well as the family. And then how to inform the prognosis to the family. So I think this would have been dealt in detail in the communication session, but just to brief, I would like to say that you have a meeting with the family. First of all, have a meeting with the family. The wife is there, the son is there. Just allow them to speak first, allow them to ventilate their feelings, what they have. And we just don't know what they have perceived in their mind with all the treatments that is ongoing. They might have thought that it is very positive already, so he might come back, things are going in a right place, because we have given so many medications, so many antibiotics every day. We can see that this patient had sepsis, and it was managed with antibiotics. So many antibiotics we could see in the medication chart. So obviously they might have a little bit of hope that everything is going well. So have a discussion with them, and first try to understand what they have perceived in their mind, and after that you start speaking about the prognosis, about this particular patient's prognosis to the family. So that is very, very important. As sir mentioned in the previous session, you can have a rough prognostication based on the PPS scale, as well as this patient is a cancer patient, so you can just apply that and see what is the I mean, like, an approximate prognosis, and then start speaking to the family regarding the same. And also you have to understand their wishes as well as the patient's wishes. So there might be a point of collusion also between between the patient as well as the family. They might have not told that this patient particularly has a metastasis or not. The patient also might not know. Because of that, he might have a lot of stress, lot of things running in the mind. Sometimes he might feel, okay, my condition is deteriorating, I know, but why nobody is talking to me regarding that? So obviously it is very important that you need to understand from the family's point of view, and also speak to the patient separately, or even if he is comfortable with the family, then okay. But you have to start speaking to the patient to understand how he actually feels. And then if there is a matter of collusion, if there is collusion, and if he really wants, if the family wants to break the bad news, then you can inform them. So that is one thing. So yes, here the patient is intubated. Yeah. So HK Das mentions that I do feel the grief and bereavement support services can be added. Yeah, exactly. And yes, here the patient is intubated. Yeah, that is something, some difficult situation where we find it really challenging to manage, right? So that is something we need to keep in mind. And how to manage nutrition in Ryle's tube feeding. So here the patient is on Ryle's tube for so long, and he can't communicate. That is one important challenging aspect. And we don't even know whether he wants to continue the Ryle's tube feeding, whether he feels comfortable with the Ryle's tube feeding. But as far as we are concerned, what we think is we start feeding him routinely, properly every time. We have a diet chart. As Dr. Bharat said, there is a dietitian, a nutritionist there in their hospital setup. So I hope they might have prepared a chart, and based on that, nutrition would have been taken care of. But most of the patients that we see who are with Ryle's tube feeding, often they have a thought that they need to taste the food. A little bit of food need to be, mixed with the saliva, because that is what we all live for. Every day we think about, whenever we see food, we think about it, we start eating it, we have it in our mix it around, and then we have it. So obviously that feeling is lost whenever a patient is on Ryle's tube feeding. So we actually don't know how he feels with the Ryle's tube, whether he is comfortable, uncomfortable, and all of that. Yeah, so here I can see Prasanna Menon mentions that 6 feeds 150 to 200 ml with rice water dal with protein and millets can be given. Yeah, okay. So yes, so that's what is in the chat. Anything else you want to add? If they can swallow, a small quantity can be given through mouth for taste. Yeah, exactly. Maybe a little bit of, because when they are when they are on Ryle's tube and all of it, obviously they, because of all the medications that has been ongoing, they might have dry mouth and all of it. So here what you can do is like, what we suggest is like a little bit of ice cubes or ice chunks, maybe just rubbed over their lips, or even pineapple, a few pineapple chunks, or even lemon juice which is mixed with water, a few drops can be given. So that's all that we can do to prevent xerostomia. And also lip care and oral care, which is very, very, very much important in a patient with Ryle's tube. Proper oral care is very much important in a palliative care setup, or in anywhere. Whenever we just examine, you just open, as a patient, to just open the mouth, or if the patient is unconscious, with a spoon, 2 spoon technique, what we do is like we just open the mouth, look for the area, and then see if there is any candidiasis, any source of infection in the tongue and all of it. And then we just using water as well as soda bicarb, we just make a mixture and then wipe it all over, clean it, and keep it very clean often. And if there is any candidal infection, we just use antifungal liniments for it. So that can also be done. Yeah, your oral care is the key message. Yeah. Here, as you can see, aspiration is also a possibility. Yes, that is very important. So here you have to whenever you have a patient here, it's not that only the nurse have to feed him all the time. What we can do is you can train the caregiver even if they go home initially for a couple of days, with the help of a palliative care nurse, with the help of a palliative care doctor and the team involved. You can just demonstrate and explain how a proper rice tube feeding has to be given. And after that, you can ask the caregiver to do it in your presence. Make sure that things are being done properly. And then once it is all done, then you can leave the patient back to home. You can discharge the patient, send them home, so that you can also make sure that this particular caregiver knows very well about how to give a proper rice tube feeding as well as oral care. So whatever I have mentioned in the previous thing also, it's very important that the caregiver understands how to do all these things. Respite care. So yes, caregiver fatigue is something which is definitely going to be there, because this patient, as you can see, has underwent a lot in the past. There are financial issues, so many things. A single caregiver, wife being there and taking care of him for so long. If there is an option for respite care, then yes, we can consider that also. First oral feed in such patient is always done in presence of doctor to look for aspiration. Yeah, okay. So yes, radiotherapy, the fourth question is the radiotherapy required for this client. So I would say I think I cannot comment on the curative radiotherapy part, as I am not an radiation oncologist, but as concerned with the symptoms. For example, if the patient is in pain, pain is something which is a very distressing symptom, obviously. So for 1 or 2 weeks, a palliative radiotherapy can really help with the pain relief. So in that case, if this particular patient, you can take an x-ray, you can take a plain x-ray, just see if there is any metastasis, vertebral metastasis or something. If that needs a palliative radiotherapy for symptom control and to improve the quality of life of this particular patient, I think it is essential that you give them that is a palliative radiotherapy. So that can be an option. After after you look into that in detail, you can have a team discussion and then decide and send the patient for a palliative radiotherapy, which will really give a good pain relief for a few weeks. And physiotherapy, I think I don't have that much of expertise to answer this question with respect to this particular patient. Is physiotherapy required for this client? Sir, would you like to add something?
Yes, I would. But first, if you want to go on to the next question, also conclude that, and then I'll come in, rather than interrupting you.
Okay, sir. Is resuscitative measures needed even when a client is in palliative care management? As for the setting where I work, I would say it is a palliative care setting where I work. So it is completely different. Here, people understand that even while we admit the patients, we totally explain that this is what we are going to do. This is what they are going to expect here. So make them understand and see what are their they might have different things in mind. They might assume also, like, when they come into a hospital, they might think, okay, here there'll be oxygen cylinders, there's going to be ICU, there's going to be ventilator. Even like we have seen certain patients who, after coming and getting admitted, they would ask us, even after explaining everything, they would that is basic human thing to come and ask. When the patient is deteriorating, they would come and ask, can you put him on a ventilator, or can you shift him to an ICU? ICU? Can I see an ICU intensivist now? So it all happens. So it is very essential that a good communication actually is very, very, very important whenever we deal with patients and families with serious, not only with serious health related suffering, but everywhere. A good communication is something that can help us understand them better. So when he is on a palliative care management, obviously we are not going to resuscitate this patient. So they need to understand where they are, and whether they are okay with what is ongoing here. So that is important. So I think communication is something which is very important when such situations arise. Okay, so that's all.
So,
And
thank Hash, specifically about the question, physiotherapy. Yes, one word answer is yes, but nothing that will cause suffering to the person. Sometimes the physiotherapy, I mean, we need to make sure that the focus is not on the joint or muscles, it's on the person. And people can enjoy physiotherapy, including a bit of massage, to prevent further deterioration and for treatment of symptoms. But I have some other points to make. Hash or Sri, can you stop that screen share? Here are the medicines that the person is getting. Sorry, not that. I'm sorry, I got the wrong document. Stop share. रुकावट के लिए खेद है. These are the medicines that are given now. It's fairly clear that the person is unlikely ever to get up and walk again. There are 4 antibiotics, the first 3 as well as cefixime, including meropenem. I'll leave you to decide on that, but look at the highlighted things. The person at that stage of the illness, pancreatin, antioxidants, hepatoprotective medication, statins, which cause tiredness, fatigue, human albumin, which there's enough publication that towards in somebody towards the end of life, this actually causes more harm than good, because increasing the plasma volume may actually reduce the lung function by reducing the elasticity, and it doesn't really help in well-being. So what I would like to ask is, if there are medicines that do not help with feeling good, should we concentrate only on the serum proteins, the chemistry, and continue to give them? At a certain cost, is that justifiable? I think not. But some things cannot be avoided, and that's related to a question that was asked earlier by Pooja. The anti-anginal medicine must continue. Anti-epileptic medicine must continue. Modafinil, I will leave it to you to decide. The medicines given for respiratory well-being need to continue, no doubt about that. But some of these things that we give very often with poor evidence, particularly in a person who is gradually nearing end of life, I don't think is justifiable. So, Dr. Bharat, maybe those need to be relooked, not only for this patient, for every patient. You go through the list and ask ourselves, is this going to make the person feel better? That's the question we should ask. Some of the other questions we had already answered during the earlier session, and I see that it is already 6:30. Sri, do you want to take any final burning question?
Dr. Hashmat would be the right person to answer the answer.
Sorry?
So, if even Dr. Hashmat feel that there are any.
Okay. No, but let me take the final chance. A chat box question talked about possibility of aspiration. Dr. Bharat, the answers were given. I would just like to add that in your presence, the first feed would be 2 spoonfuls of clear water. Not milk, not any other food. If at all aspiration happens, which can possibly in somebody who has been intubated for some time, that's transient. And to avoid harm during this, that's why we give plain water as the first feed. And once we understand that can swallow, then we proceed with more. Now, just because of fear of aspiration, not trying that also is not justifiable. The person is being given an opportunity to have the pleasure of swallowing something. Thank you.
Thank you, sir. I think if there are no more questions, I can see that in the chat box, there are no more questions. So if there are no more questions, we can end the session for today. Over to you, Shri Priya.
Thank you, sir. Thank you so much for joining us. I personally know your days are much packed recently, even after back from the EPICON, you are continuously traveling, continuously attending meetings, and still you found out time for this wonderful batch. Thank you so much for that. And I believe each one of you had benefited from this session. And we sincerely hope that all the learnings you have taken from here do benefit in your practice as well. So, with the promise that we'll be meeting again in the next session, which is going to be our last session as well in this foundation course. This is Sri Priya along with Dr. M. Rajagopal and Dr. Hashmat Sohana signing off from the TIPSICO Hub. See you in the next session. Till then, everyone, take care. Bye bye.
Bye.